So I'm going to be talking about what we know we don't know, and it sounds a bit sort of like Rumsfeldian. And the first thing is that it's important to understand that there are only some streptococci, group A strep, which cause rheumatic fever, and these are the rheumatogenic strep. But it's really not known specifically which group A strep, and it's also not known which are the specific genes that have this capability in the susceptible host to cause rheumatic fever. And similarly, it's thought from the epidemiology that only 3 to 15% of any population is susceptible to getting rheumatic fever through an immunological process that they are particularly that they have particularly in their makeup when they're exposed to a rheumatogenic strep. And it's this abnormal immune response that causes acute rheumatic fever. And one of the things that this afternoon we're talking about is that this genetic susceptibility is not ethnicity based at all. It's entirely present in every single population globally. So if a susceptible person has exposure to rheumatogenic strep, then there is the potential to get acute rheumatic fever. But what's clear is that this no longer happens in the affluent communities around the world. And so there's a whole other aspect to the process which is, again, not very well understood, and that is this issue of why is it that despite the fact that 3 to 15% of people living in Toorak or in the North Shore of Sydney, Vaucluse or any of those fancy places, and they're still being exposed to rheumatogenic strep every now and then, why aren't they getting rheumatic fever? So I'll come back to that briefly. So the rheumatic fever process, just like APSGN, which is acute post-streptococcal glomerulonephritis, both of them are known to follow throat strep infections. And the history of rheumatic fever, which came out of the United States really, the understanding of the epidemiology was that it was the streptococcus being the chain, as in the chain of streptococci, that links the throat to the heart. However, the epidemiology from the Northern Territory and similarly seen in WA and Queensland would suggest that skin strep have a big part to play as well. It is known that it's been known for a long time that skin strep, as in skin sores, as well as throat strep, can certainly cause post-strep GN. So what is it that's missing here in our understanding? And the understanding is, first of all, two things. One is, where does skin fit into it? And secondly, why is it that rheumatic fever is no longer occurring in affluent communities where there is still occasionally circulating rheumatogenic strep, and there is still a population which is susceptible as it was in the slums of Melbourne and Sydney 100 years ago? And the answer to that may well be that the priming is required from an immunological point of view from multiple infections in early childhood, particularly in the first few years of life, which is exactly the scenario that we see in Central and Northern Australia and right across to WA and Queensland. So in other words, that when you break those cycles of repeated streptococcal infections, mostly in our context skin infections, then even those susceptible people possibly never reach a level of priming which makes them susceptible to getting rheumatic fever. So this is where we're at with our understanding, and it really is still a very rudimentary understanding. We don't know the specifics of the immune response, and we don't know the specifics of the genetic makeup of the rheumatogenic strep. This is just really the first evidence that was put forward about this priming concept, and I showed this afternoon, and this is John Matthews, who is the Foundation Director of the Menzies School of Health Research in Darwin. I originally saw this. He comes from an epidemiological background as well as a clinical background, and he put this schematic on the board reminding us that when we think about this as clinicians, impetigo can certainly occur in the first year or two of life. Post-streptococcal glomerulonephritis, the average age at which it occurs is between 5 and 10, whereas the average age for rheumatic fever, as we heard from Claire, is 5 or 10 to 15. And yet people are being exposed to strep within the first year of life. And so this is really the first time people had, and I attribute this very much to John Matthews and his forward thinking, that there is something going on with repeated exposures that is priming people to the potential of getting these immunological diseases subsequently. So what we know we don't know is, who are the 3 to 6% that is, or 3 to 15 or 5 to 15%, depending which papers you read, who are susceptible in any population? What it is known is that some of the immune markers that have been found in some of the studies may be different between ethnic groups. So the studies, the B-cell alloantigens that were found in the in the Indian subcontinent, in South Asian population, were different from those that were found in New Zealand Indigenous and Australian Indigenous population. But the bottom line is that the percentage susceptible is still thought to be the same across the board in any ethnic group. And we don't know, as I've said, what the immunopathogenic process is. What we need a blood test as a diagnostic for acute rheumatic fever, because although we have now a fantastic app, which Christian has got everyone to load at the meeting today to help with diagnosis, and we have our algorithms, the Jones criteria and the revised Jones criteria, and the recently re-revised Jones criteria, which brings echocardiography into the diagnosis of subclinical carditis. Despite all of that, what would be brilliant is if we had a blood test, and we can say this kid who has polyarthralgia or polyarthritis has rheumatic fever because the blood test tells it it's rheumatic fever. There is no blood test. We have blood tests for streptococcal antibodies, but that's not the rheumatogenic process. We don't know which group A strep M types are involved. Of the over 200 different M types, they're all the different, what were originally serotypes, but it's now done by genetic typing. Look at the M gene, which confers or codes for the M protein. There are over 200 of these. We don't know which of these and which subset are the rheumatogenic ones. And we'll be hearing tomorrow a little bit about Group C and Group G strep, and there is clearly some evidence that some of these other streptococci, which are not Group A, can be the cause of rheumatic fever. And the interesting thing is when people have looked at these Group C and Group G streps is that they have genetic material in them which is in fact probably originally acquired from a Group A strep through horizontal transmission. So either on the skin or in the throat, you've had cohabiting Group A strep and Group C or G strep, and there's been movement of genes from the Group A strep, potentially rheumatogenic genes, into the Group C and G strep. This is a current thought, but again, that needs a lot more work. And I've already mentioned, what have skin strep got to do with it? We think they're absolutely central to the overwhelming problems in central and northern Australia. So, stepping back a bit to look at it, I think that this is how I think that it needs to be looked at for those of us who, at the clinical end, which I'm predominantly at, to the public health physicians, and then those working in social sciences. We've got the primordial aspects of housing, health, hardware, education, employment. On the public health side, we've got preventative programs, and then we've got, on the clinical side, standards of care and best practice. And each of those is a legitimate area for research. Social sciences research to understand what are the barriers in communities to uptake or adherence with things. What are the barriers in good service delivery provision by our health staff? Why is it that so much of a focus in these incredibly stressed remote community clinics needs to be on acute care, which is, the sick kid coming in with the mother or someone who's just had some trauma? Of course that will take priority, but how can things be re-geared in some of these communities to look at some of these preventative programs in a more holistic way and a more sustainable way? And biomedical research is absolutely legitimate. The reason being, as I said this afternoon rather crudely, maybe I thought afterwards maybe I was being a bit crude, was that social justice is not going to happen in Australia in our lifetime, the way things are politically. We are going to need a streptococcal vaccine because we're still going to have impoverished people living roughly and in overcrowded conditions in remote places. 20 years ago, 25 years ago, the Minister for Aboriginal Affairs, Federal Minister, who was a doctor and very well-intentioned, said, by the year 2000, I defy anyone to tell us we have poverty in our remote Indigenous communities. That is by the year of the Olympics. And that was said basically 5 years before the Olympics. Now, do we really think things have changed that much, that in central and northern Australia that everything's really looking good from the point of view of the social justice and the equity issues? So my point being is biomedical research will enable us at least to have other tools in the armamentarium, such as a streptococcal vaccine. So you've got clinical, you've got public health, infectious diseases. The problem with some of these classifications of diseases is a lot of the infections get classified under chronic diseases. Now, as an infectious disease physician, I can't say that chronic diseases are not that important. Of course, diabetes is sort of important, I guess. Renal disease, renal disease is an issue. What we now recognise is infectious diseases, as Claire knows, infectious diseases in childhood is the antecedent to the renal disease and also probably to the problems of the diabetes. But we do need to understand the biology of the pathogens, and we also need to understand the sociology of families, communities, society and health staff and health services, how things can be made better at both the biomedical side and at the social sciences area. So primordial prevention of rheumatic fever, rheumatic heart disease, housing, education, employment, communications, transport, access to services. But, so the big picture. So Puggy Hunter, who was legendary in Western Australia, and I was very fortunate when I first moved to the Northern Territory of getting to know Puggy a little bit, and his incredible advocacy as the NACCHO chairman a long time ago, just after the Olympics, where we were meant to have a completely egalitarian society. So Puggy said, I keep saying that I don't care what colour you are or where you come from, but if you're living in a small house with large numbers of people, then you're going to get sick. And then this is the science behind that. And what Puggy was reflecting is also what's shown by science. The number of people per bedroom equates in a linear fashion to the rate of skin sores or pyoderma per population, as in presenting to health clinics. And Ross is here. Ross Bailey, where's Ross? Ross, yeah, so that's one of your papers there. So I was wondering why you came tonight. And Ross, of course, is the 12170, which is the continuous quality improvement for rheumatic heart disease, has been so critical because that can then put back into the community health centres how you might improve your service delivery side by looking at various parameters of service delivery. However, in my list of what we know we don't know, we're now up to how to make primordial prevention a reality. I mean, we've been talking about this for however long, and Claire mentioned it, and to me this is what we don't know. And we know we don't know it, and if you think you know it, then you're kidding yourself, would be what I would say. We know what equity is, but how do we actually get there? Okay, so this is, and again, one of the other things is to learn from the old literature. And someone showed me this old data recently when we were talking about this primordial aspect and about housing. And this is a brilliant work that was done where a lot of the work about rheumatic fever was learnt from the US military and the boot camps where they brought people in from all the different parts of the United States. And they came in with each of their own streps to which other people hadn't been exposed from all the different parts of the 50 United States into these massive boot camps, such as Warren Air Force Base in Wyoming. And what they showed was that as far as acquisition of group A strep in the throat or on the skin, it was all about how close the beds were together. So if the beds were less than 5 feet apart, then there was greater than 60 strep acquisitions per 100,000 man weeks. There was no women in these beds, I can tell you there's just men, or as far as we know. And then when you make it, but when they moved the beds as an experiment to greater than 30 feet apart, it dropped dramatically. So that is immediately telling us one aspect that we should be thinking about in relation to crowding and the number of people per bedroom. And our New Zealand colleagues figured, they emphasise this housing is important to reduce rheumatic fever, says GP. Okay, so this is a bit crude. You talk about funding holistic health. You've got funding for the kidney, funding for the eye, funding for the ear. Tell me, have you got funding for the arsehole? And and I put that up there to remind myself that it's not just about rheumatic fever and rheumatic heart disease, which we're passionate about and people here are passionate about. And Puggy was continually telling people that, this siloing of diseases based on organ parts. Maybe there is funding for the arsehole now, I'm not sure. Maybe, are there any colorectal surgeons in the audience? It's probably, and maybe with the Ford estimates, they're going to get better funding than we are. I mean, who knows? So the point is that primary prevention of ARF, RHD, we've talked about all of those things, is exactly the same as primordial prevention of pyoderma. Same stuff. And this is what Puggy was getting at, as in for scabies as well, as is for trachoma, which has all the same antecedents. So this is just about bringing the thoughts around these processes together, because when you think about it, in remote communities, you've got your trachoma team, you've got, as in you lot, and I'm not trying to give you a hard time because you're doing a great job, that our colleagues here from the different programs, you've got your rheumatic heart disease team, you've got the diabetes educators, and so on and so forth. So somehow there's so much overlap between what could be done and ways that could be brought together. So making primordial prevention a reality maybe should be looking at the big picture as well across all the diseases. So the finally is how to best... So these are some of the other things that we just don't understand fully. We have in our guidelines in CARPA, which is the Central Australian Rural Practitioners Association Manual of Primary Care, and we have in the Therapeutic Guidelines Antibiotic, which are our Australian national guidelines, about treating sore throats, and it says most sore throats are viral, but in risk populations, give antibiotics in case it's a group A strep to prevent rheumatic fever. But where do we draw the line for that remotely and in the Australian context? What about in the urban disadvantaged communities, particularly the Pacific Island communities in Sydney and Brisbane? How often should they be getting penicillin to prevent possible rheumatic fever? We know, and it's Ash Dixit, where's Ash? Ash is here. Ash Dixit is here, who is really helping us with understanding benzathine penicillin, which has been around now since the 1940s when it was developed, which is two molecules of benzyl penicillin joined together to give it a long half-life. It's a brilliant and appropriate medication, but we don't fully understand where it's going when we give an intramuscular injection. Where is it hiding out so that it can prevent the infection in the throat and the skin? How do we optimise secondary prophylaxis using it, which is the 3 to 4 weekly injections? What is the best dosing? Should we be using bigger doses? What are the best dosing intervals? When do they have 4 weeks? When do they have 3 weeks? What about adherence? That's a massive issue, and we'll hear a lot more about that. What about the pain? How do we minimise the pain? What about the site? There's talk about two different parts of the buttock and one part of the thigh, and we will hear about more of that tomorrow. Lorette, what's the 3 different ways now that we have a video which says 3 different ways, and it confuses people, but the right thing is to give them the option. So what are the 3 different places we can give the injection?
So, well, it's the ventrogluteal side, is obviously the most controversial side.
The ventrogluteal side, which is?
And so that's still in the side of the buttocks, and then the upper outer quadrant is the more...
So the upper outer quadrant's historical, and the ventrogluteal of the buttock, and then the thigh. And there was a study in... Sorry, go on.
No, it's just... It's kind of always interesting to hear how many people are actually comfortable with all 3 sides.
Which is not that many, because we do it differently in WA and NT and Queensland, because, of course, we're all different. And you know, the only thing that's the same is that Queensland has given us all cane toads, but apart from that...
But the issue, obviously, is that we want to get it into the muscle.
Exactly.
And not in the fat, so that's...
So we think you want to get into the muscle and the fat. So they did a study in Canadians where they gave injections intramuscularly, they thought, into the buttock, and did a CAT scan, and they found that nearly all of them were into fat. Now that was Canadians, and Canadians can be pretty big people, but so the question is, how often are we really giving the injection into fat as opposed to into muscle? And in fact, maybe it's even better in fat. We have no idea. No one's really studied it. In fact, the majority of adults getting an intragluteal at either of the 2 sites injection are probably having it deposited in the fat, not into the muscle. I think that would be a reasonable statement, particularly with the current syringe, because how many of you remember the old horse syringe, which was the 17-gauge needle? It was actually 18 gauge. Some people thought it was 19. The point is, it was about this long, and it was called the horse needle, and it definitely got into the muscle. And this is the key performance indicator. This is for the paediatricians in the audience. There's only one key performance indicator that I think is important, and that is that no child in Australia should be dying from the complications of ARF or RHD. I showed this afternoon. These are 2 of the children and a young adult that I was involved with in Darwin some years ago, both of whom died, and they're their final images. And it's just, this should not be something that we are seeing in Australia. And my final slide is that we don't know about the funding, and this is, where's Jen? Yeah. Jen, so in South Australia, they don't know what's happening with their funding come this next budget, and we don't know beyond the middle of this year. And everyone's spending a lot of time agitating, writing to politicians, saying we need to be sure of funding, and that's taking up a lot of resources. And if we had consistent funding for the next 5 years, we would be able to get on and do the work that everyone agrees that we should be doing. So I think this issue about cycles of funding which go for a couple of years is disastrously time-consuming and very frustrating for staff, and good staff often move on to get another job because some staff don't know what they're going to be doing in 3 months' time. I think that would be a reasonable thing to say because of the budgets. Is that true in Queensland?
All staff that are employed under the statutory do not know what they're doing.
And this is a Commonwealth government, not the Queensland government. It's the Commonwealth government, and they've got to get their act together and try and, if they're serious about, sustainable aspects of rheumatic fever, rheumatic heart disease, they need to basically, in my opinion, have a longer-term strategy and not have these cycles of funding which are just so difficult for us to get on and do what we need to do. Oh, this is another one. This was just to say there's nowhere near enough we need more nurses and doctors working remotely. So those of you in Brisbane who want to come and work remotely, in WA they're really short at the moment, in the Kimberley and Pilbara, in the Territory, we need you all. And in remote Queensland. So that's the end. I think that's my final slide. That's all the things we don't know. We know. So thank you.